help put Louisville on the map as far as moving it forward research-wise. So normally these lectures would involve bringing the speaker and his wife down here. We would go out to dinner. We would have a great time. We're obviously not doing that this year. And I talked to Dr. Redinger for about an hour yesterday. He's still farming out on the farm, doing great. He can't join us today. When we had grand rounds in person, he and his wife would always be down in the front row, but they have terrible internet access out on the farm. So we're taping this and we'll take the lecture out to them so they can both see it. But we're thrilled to have our speaker today, Dr. Naga Chalasani here. That Naga and I have been friends for 15 to 20 years. I've followed Naga's rise through his career in academic medicine, and Naga is a native of India. He did his residency and fellowship at Emory. He went to IU in 1997, and in 2007 he became the director of the program. And IU has a very broad-based GI program, and Naga's just done a wonderful job there. In 2017, he became the Associate Dean for Clinical Research, and this year he's taken on another hat. I don't know whether this is a good thing or not. He can tell us about that maybe, but he's the interim chair of medicine also, so he does a lot of things at IU. But Naga is internationally recognized for his translational research in non-alcoholic steatohepatitis, alcoholic liver disease, and probably most importantly in drug-induced liver disease. He consults for a ton of different companies, and he does this in part because they all know the importance of drug-induced liver injury in the development of new drugs. So this is the main reason that drugs don't make it to market, new drugs. So today, Naga is going to tell us about drug-induced liver injury, which is a problem that we all face. Naga, take it away.
Thank you, Craig. Good morning. I hope you can see me and hear me well, Craig.
Yep.
Thank you. I really want to thank you for this invitation. This is truly a privilege to be speaking at Dr. Redinger's lecture series. I wish this was in person. I was looking forward to it, but we all know what COVID has done to almost all of these kinds of events throughout the year. I do look forward to visiting Louisville sometime soon. We do, as you know, we share a couple grants, one in URO1 with Matt Cave, and then we are part of the AGAF net that Louisville is playing a big part in. Please take a moment to look at my disclosures. I have some consulting agreements, mostly in the areas of NAFLD and non-alcoholic and drug-induced liver injury, some research support. Our institution forbids any speaker bureaus, so therefore I have no speaking commitments. So what I'll do, I don't have an outline slide. What my talk will cover background and definitions of drug-induced liver injury, which I'll call DILI. I'll touch on what are the common compounds or medications and herbal agents that cause DILI. What are the risk factors? Finally, we'll be touching on some classes of agents, for example, immune checkpoints, and also Dr. McLean just reminded me to talk about statins and their lack of significant hepatotoxicity. Let me get started. Drug-induced liver injury, it is important because it causes up to 10% of acute liver injury cases in the United States. And it's actually a worldwide problem as well. If you go to China and some parts of Asia, you see a fair bit of drug-induced liver injury, but related to herbal agents. It is the single major cause of acute liver failure in the US. And as Dr. McLean has said, this is probably one of two most important reasons why drugs fail, and especially when they get to phase 2B, phase 3, where hundreds of $1,000,000 have been spent by the pharmacy already. There are many examples why, uh, you know, of withdrawal or restriction of use for an approved agent. You know this list, majority. Within last 5 years or so, we have seen tolvaptan with a black box warning, as well as it was not approved for use in polycystic kidney disease just because of hepatotoxicity, and obeticholic acid, which is now approved for primary biliary cholangitis, has a black box warning for because of liver failure. This is a slide now 78 years old from Dr. Will Lee's US acute liver failures registry, highlighting the point between acetaminophen and drug-induced account for about 57% of all acute liver failure cases in the US, just highlighting the importance of this entity, at least as it relates to hepatology practices. There are two different forms of drug-induced liver injury. One is direct, the other one is idiosyncratic. These are different phenotypes of injury, and these have very different implications for etiology, outcomes, and pathobiology as well. Direct hepatotoxicity here, this is dose-related, and if you take enough of this compound, just about everybody who takes it will get this toxicity, and outcomes are predictable. And then the prototype is acetaminophen, which I will not be talking about today. This talk will be largely focused on idiosyncratic, but other examples of direct hepatotoxicity include aspirin, niacin, many of the anti-neoplastic agents. Typically, you see high aminotransferases. Even in the higher concentrations, it can cause hepatic necrosis. Some other phenotypes include sinusoidal obstruction syndrome, lactic acidosis, and nodular regenerative hyperplasia. This is more sort of a chronic direct hepatotoxicity, something like, for example, azathioprine may be causative here, and this is more related to endothelial injury and sort of reorganization of hepatic architecture. Idiosyncratic hepatotoxicity is sort of the intriguing type of DILI because the event is unexpected. It happens when you don't expect, and it is rare, and is generally thought not to be dose related. We have done some work to show why this is not entirely true. Probably the most well-known today is isoniazid, which continues to be a major problem worldwide because of its hepatotoxicity. You go to South Africa, some other TV bells, you see isoniazid hepatotoxicity. Amoxicillin clavulanic acid is the most important cause of DILI in the US and the Western world today. Minocycline, trimethoprim, sulfamethoxazole, diclofenac, these are some other examples. Just about any compound. Most compounds can cause idiosyncratic DILI if the exposure is large enough. It is idiosyncratic. The biology is thought to be either immunologic or metabolic or a combination of both. It can present as multiple phenotypes. I do have a slide to share on this, so I can discuss more. Etiology is generally unknown. This is a challenge for clinical and basic research because there isn't a good animal model to reproduce. And there is a fair bit of research in the genetic space, and which is very small incremental improvement in our knowledge there. Indirect hepatotoxicity, this is something coined by Dr. Jay Hoofnagel, who is sort of a major figure in DILI from the NIDDK. Here, a medication induces a liver disease or alters a pre-existing condition. Sorry, it's a typo there. For example, you take TNF-alpha antagonist and you reactivate hepatitis B. Or, for example, you're giving immunosuppression that leads to a flare of hepatitis C, or some compounds can trigger autoimmune hepatitis. And for example, some psychotropics can exacerbate non-alcoholic fatty liver disease through weight gain. And can be predicted. The importance of this entity is knowing that this can occur so you can prevent or can avoid. The definition, if you go 20 years ago for DILI, it was biochemically, if you had twofold increase in ALT, that was sufficient to cause DILI. But in light of background fatty liver disease, many have these fluctuations of ALT. The revised definition for DILI requires that the ALT should at least be 5 times of upper limit of normal, or 2 times of upper limit of normal increase in alkaline phosphatase, or 3 times upper limit of normal ALT plus an increased doubling of total bilirubin. In the absence of a competing etiology, this is really important. DILI is a diagnosis of exclusion. You need to exclude the common etiologies that can cause increase in ALT or liver biochemistries. Touching on the incidence of DILI, very few data, population data there is a paper from Iceland now published 6-7 years ago by Professor Einar Bjornsson, looking at the incidence of DILI in Iceland. He showed that at least in that country, the incidence was 19.1 cases per 100,000 inhabitants. And Dr. Vic Navarro's group from Delaware did a similar study in Delaware, showed that the incidence was 2.7 cases per 100,000 of adult residents in Delaware. So the Iceland study used ALT 2 times of upper limits of normal as the definition for DILI, whereas the US study from Delaware used ALT 5 times of upper limits of normal. Therefore, that explains lower incidence in the US. But then if you look at jaundiced cases, this is about 5 jaundiced cases per about 100,000 people per year. This is approximately what's seen in the US as well. This is in sort of an interesting estimates of risk of DILI among exposed individuals. This is from Dr. Bjornsson's paper from Iceland. What I'd like to point out, though, is azathioprine, which is used in multiple subspecialties, seems to have the highest risk among exposed. Doesn't mean that this relates to severity. 1 in every 130 people received azathioprine had DILI. And then you could see the frequencies. Amoxicillin clavulanic acid is by far the most common reason why we see patients for DILI. And this is a cholestatic pattern. This is about 1 in 2,500. And the rest you can see here. This is a paper that we published now about 5 years ago. There is a NIH-funded network that I've been part of as a PI called the Drug-Induced Liver Injury Network. This has been ongoing since 2004. And as this network has now about 2,500 well-phenotyped cases of DILI from across the country. There are now 5 centers in the US enrolling patients. This is a report, this is 5 years ago, consisting about 900 patients of true cases of DILI where the causality was definite, highly likely, or probable. What I'd like to highlight is the antimicrobials is the largest therapeutic class to cause DILI in the US, followed by herbal and dietary supplements. This is consistent in the Western world. Antimicrobials are the largest class, and it is unclear why antibiotics or antimicrobials have a high risk for DILI. 2 theories. One is because of infections, there may be background endotoxemia that primes for DILI. The other one could be the dose of a compound that antimicrobials, typically you take in higher doses, right? You're not taking a milligram of ciprofloxacin to treat an infection. And if you look at individual agents, amoxicillin clavulanic acid is by far the most common, followed by isoniazid. In top 10, what I'd like to point out is 9 out of top 10 are antimicrobials. And this is sort of the same experience from Sweden, Spain, Latin America, that the antimicrobials sort of feature dominantly as the individual agents to cause DILI in the US. So when I started to work in the field of DILI, there was this dogma that the idiosyncratic DILI is entirely dose independent. But one thing I was picking up in early 2000s, late 1990s, when I was a young faculty, all the medications that were getting into trouble from the FDA in terms of liver liability, they all were given in higher doses. If you look, though, these compounds that are given at daily doses under 10 milligrams, they really don't cause serious liver toxicity. This led to Craig Lammert, who then was a medical student, and I looked carefully using some databases, and we found that there was a dose relationship, and we found a threshold of 50 milligrams per day is where you start to see hepatotoxicity. This played out subsequently in other studies that I'll touch on in a moment. And in a subsequent study, Craig Lammert still was a medical student before he moved to Emory as a resident. He is now a faculty at IU. We looked at a compound's metabolic hepatic metabolism as a risk factor. And in our theory was if a compound is significantly metabolized hepatically, it may release reactive metabolites, therefore causing hepatotoxicity. We found the same thing. If the compounds with extensive hepatic metabolism, which we defined as at least 50% or more hepatic metabolism, once again, we saw this signal that they're more likely to have this hepatic liability of 200 most commonly prescribed medications in the US back when we did the study. And then in the same paper, we combined the dose and extensive hepatic metabolism. And there's clearly this signal that if you're taking a compound that is at a daily dose more than 50 milligrams and is hepatically metabolized, there is clearly higher risk for hepatotoxicity. This is lower sensitivity but higher specificity for these characteristics. Based on what we observed, investigators from the FDA put together this rule of 2 and rule of 3. Rule of 2 is daily dose more than 100 milligrams per day on a lipophilicity more than log P greater than 3, on a rule of 3. And the importance of this was guidance to drug developers to say, if you're looking for a compound that is not likely to have liver liability, choose something without these characteristics: small molecules at a lower dose, lower lipophilicity, and the reactive metabolite formation is lower, non-existent. And there's some controversy. Some experts in the industry don't accept. And this is, by the way, it's not hard and fast by any means. Just want to touch on some things that may be relevant for clinical trialists in the field. When clinical trials are done, if you're looking in clinical trials for hepatic safety signals, keep in mind when the clinical trials are done, they're not powered for safety, right? When you look at sample size calculations, they're powered for efficacy. So you really need to have very fine eye to pick up any liability when the compound is given to millions more once it's approved. There are 3 phenomena that the FDA looks when in clinical trials. One is called Hy's Law. This is from late Hy Zimmerman, who's sort of a legend in the field of drug hepatotoxicity. He made this observation: isolated hepatic aminotransferase elevations never kills people. It is increased aminotransferases with jaundice. That is what he described as the hepatocellular jaundice that causes mortality, about 10%. Where he drew this observation is from isoniazid. Now, to most part, it plays out. If you have a compound that in a clinical trial has this Hy's law, that is considered to be a major liability unless this compound has been developed for very significant illness such as cancer or multiple sclerosis. There is Temple's corollary where Bob Temple, who is also an expert at the FDA in drug hepatotoxicity, what he found is that in clinical trials, there needs to be an imbalance in ALT 3 times upper limit of normal to lead subsequently to hepatotoxicity. This is sensitive but not specific. There are many compounds that cause ALT increases that never lead to hepatotoxicity, serious hepatotoxicity, let me say. For example, statins is a great example where statins cause ALT fluctuations, but the risk of jaundice is extremely rare. And then finally, if in a clinical trial, ALT, if you see a case from a drug, more than 10 times our upper limit of normal, that is not a good sign because there is this relationship for every 10 cases of 10 times upper limit of normal ALT, you will see one Hy's law case. If you see one Hy's law case, that means that for every 10 Hy's law cases, you're going to have one acute liver failure. So this is sort of what the FDA uses to project what the hepatotoxicity might be if a compound is approved. And for some of you who are doing clinical trials, this just may be worthwhile information. This is eDish. If you are serving on any data safety monitoring boards you see, this was by Dr. John Senior and his colleagues developed this eDish plot where the x-axis is peak ALT and the y-axis is peak bilirubin. This sort of marries what late Hy Zimmerman was talking about is the ALT plus bilirubin. So upper right quadrant, where the bilirubin is at least 2 times of upper limits of normal, and then also ALT is 3 times upper limit of normal. If you have an imbalance in Hy's law range, that is a signal to the FDA or data safety monitoring boards that there may be a hepatic safety signal. Okay. Now moving into some risk factors and other aspects of DILI. So over the course of last 20 years, there's been a lot of interest in identifying genetic variants in DILI. Early on, it was all candidate genes. Last 15 years or so, we've been involved in genome-wide genotyping as well as whole exome and whole genome sequencing. I must say, to large part, this has been disappointing. When we went into these investigations, we thought we would find big hits that would cross across different agents. We thought, at least, for example, we would find signals that would just say, hey, this person is at risk for antimicrobials. Turned out there was just not such generalizability. Everything that we found to date has been compound specific. The biggest hit to date has been flucloxacin with HLA-B5701 with an odds ratio of 80. This is for every 500 patients that receive flucloxacin, 1 will get DILI. And I don't think this translated into actionable observation. And by the way, flucloxacin is not available in the US. Amoxicillin clavulanic acid is many hits, but their effect sizes are small, odds ratios of 2 to 3. Once again, this hasn't quite translated into anything actionable. And there are a number of other things, minocycline, terbinafine, fenofibrate. Interestingly, green tea extract seems to have this significant relationship with HLA star 3301. And then we identified a recent paper that we published, trimethoprim sulfamethoxazole, that there seem to be different HLA for European Americans, i.e. Caucasians, and African Americans. It is, for African Americans, it is 3501. Why this is important in African Americans, the most important cause, or most common cause for DILI is trimethoprim sulfamethoxazole. It is not amoxicillin clavulanic acid. The risk alleles for amoxicillin clavulanate are underrepresented in African Americans. from some of the work that was done by the DILI network. As I said, DILI can present just about as any phenotype. It can present as hepatitis, as cholestatic jaundice, as a mixed pattern injury. It can be silent with elevated aminotransferases. It can be dramatic. Somebody can present, especially with compounds such as isoniazid, hepatic necrosis. It could be bland cholestasis, so on and so forth. What does this mean? That means that you have to keep DILI in mind anytime you evaluate a newly diagnosed patient with liver disease, or somebody with chronic liver disease now presents with acute worsening. Then you have to think about a DILI. In my own practice, have seen in my transplant clinic stable patients take cephalosporins for cellulitis, boom, they get jaundice. I've seen more recently a very stable alcoholic cirrhotic patient becomes diabetic, gets put on metformin, rapidly deteriorates. And when we stopped metformin, he stabilized but never really regained. He needed to be transplanted. So keep this in mind. When you're stable liver patients, if you're seeing a rapid deterioration, asking about drug history or even probing about herbal and dietary supplements is really, very important. When we evaluate DILI, it is important to classify this into cholestatic and hepatocellular. Cholestatic is where more alk-phos and jaundice predominant, whereas hepatocellular, where you're seeing a higher AST and ALT. There is an R ratio you don't have to memorize, but you could just simply eyeball liver biochemistries to say, hey, are we seeing hepatocellular or cholestatic? Importance of this is twofold. One is compounds have this signature. For example, isoniazid, to most part, causes hepatocellular injury. This helps you hone down on your diagnosis. And for example, amoxicillin clavulanic acid causes cholestatic DILI. That's one, the signature. The other is outcomes. Hepatocellular DILI is the one that causes crashing and burning liver failure. Cholestatic DILI can cause bad outcomes, but it's typically you don't see this acute liver failure. And if they do get liver failure, this seems to be chronic, high bilirubin, failure to thrive, and ductopenia. So this is a table that I put together with some of the data we published, as well as from Sweden and Spain, saying the same thing. Hepatocellular DILI has worse outcomes compared to cholestatic DILI. And by the way, the patients with cholestatic DILI also die. They just don't die from liver failure, but more likely from underlying comorbid conditions for which they were taking the medication that is implicated. Very interesting phenomena. If DILI is of a mixed pattern, their outcomes seem to be quite good. Never really figured out. All series, all 4 series with large numbers of patients sort of made the same observation. This is a very interesting. This is from IU. Dr. Gabriel, one of our hepatologists, is a senior author, published last year in Gastroenterology. Very interesting. Stems from an observation that we made. So we were seeing these younger patients with isoniazid, hepatotoxicity, INR4, MELD 30. They are recovering, whereas then we would see these elderly patients with bad COPD take amoxicillin clavulanic acid for COPD exacerbation. They get jaundice, they don't recover. I started to wonder how the comorbidity plays into this. So what we have done is, in this particular paper, we identified the higher comorbidity burden, defined as Chalasani index, is really very important as MELD score in defining 6-month outcomes. Okay, this is overall death rate, not liver-related mortality. And then we developed this scoring system, this algorithm or nomogram. It actually validates quite well. We had an external validation cohort that had AUROCs of 0.95, suggesting this is a pretty important model for predicting outcomes. You should look this up when you have your next patient with DILI to plug it in so you can predict their 6-month mortality. Here the CCI is is broken into, categorized into more than 2 comorbidities or under 2. Okay. I've already touched on causality in DILI. This is a diagnosis of exclusion, and there is no specific test. There are many instruments to use. Even in expert hands, sometimes you wrongly attribute a drug as a cause for liver injury. In my own experience, when I say, hey, this is very striking case of DILI due to linezolid, turned out this actually was acute hepatitis C the patient picked up from actually an orthopedic surgeon. There was a small little outbreak in Indiana. So it is a diagnosis of exclusion. It requires that you consider all etiologies, especially if you are evaluating DILI inpatient. You have to think about, cardiovascular, liver ischemia, or other medications and hypoxia. Okay. And in our experience, we found that even in the experts' hands, up to 1 to 2% of what seem like classic cases of DILI, they can be from acute hepatitis C. Several papers written by the DILIM group and acute hepatitis C and acute hepatitis E. One thing though is sort of Midwest seems to have a higher acute, hepatitis E seroprevalence. So if something doesn't quite add up, testing for Hep C, Hep E is really important. Recent practice guidelines now recommend Hep C PCR for all cases of suspected hepatocellular DILI. Now moving to the next part of my talk, where I will be touching on individual classes of agents. The first is herbal and dietary supplements. This is a big problem. As you know, there is increasing use of HDS by American population. And we know they can cause DILI, and then we see they are being increasingly implicated as DILI causes. 2 large classes of HDS. One is bodybuilding supplements, and the other is weight loss supplements. These are the 2 classes. They have different phenotypes. Bodybuilding agents, for example, anabolic steroids, etc., cause cholestatic pattern, whereas herbal weight loss supplements, and I think this may be coming down to green tea component of these weight loss supplements, and these cause hepatocellular DILI. Dr. Hoofnagel recently published a paper from Dillon showing green tea extract. This is about 50 cases in hepatology, and there is a striking relationship to HLA-A star 3301. And once again, this is not the green tea we drink, but this is much higher concentration. Also interesting though, some parts of the world, there is just extensive use of green tea extracts without DILI. So it got to be sort of the genetic underpinning that sort of drives increasing green tea extract DILI that we are seeing in the US. This is an 80-year-old patient that we saw about 4 or 5 years ago from acute liver failure. Not kidding, this is all the herbs that he was taking. When I asked them to bring, these are the bottles. And this is a patient chair, one of our CRC. This is amazing. And by the way, when we discharged him, he demanded that he get all these back. Hope he did not go back to taking them. We've seen some interesting temporal trends in herbal and dietary supplements. Something very interesting, though, is the dietary supplement industry seemed to figure out, for example, when there is a signal for hepatotoxicity, they seem to tweak the composition. We have seen this with Herbalife. 7-8 years ago, there was this explosion of DILI cases due to Herbalife. And then the company that makes Herbalife changed the composition. We just don't see that as much. Same thing with Oxy Elite Pro. It's very interesting. We've started to see last 4 or 5 years, we're not seeing bodybuilding agent DILI. You know, we used to see 7 to 8 cases of deep jaundice from anabolic steroids for years and years. Now in the last 2 years, I think we've only seen 1 or 2 cases. This is reflecting here. The portion that's green is just now virtually non-existent. So I was talking to Dr. Hoofnagel to think why this is. He thinks this is related to FDA clamping on illegal selling of anabolic steroids and also monitoring the plants, the composition of these anabolic steroids. Now, just like to touch on some special entities. One is autoimmune DILI. Most of you know autoimmune hepatitis is sort of hepatocellular. In a genetically predisposed individual response to steroids, you have autoantibodies. But though there are medications that can cause a liver injury that looks like autoimmune, the prototypes are nitrofurantoin. Typical patient is an elderly patient who is on nitrofurantoin for chronic suppressive, as a suppressive agent against your UTIs, maybe a nursing home resident, on minocycline. By the way, minocycline is the most common cause for DILI in children, given for acne. But there are other types of compounds, TNF-alpha antagonists, statins, methyl-dopa hydralazine, can all cause autoimmune like DILI. Long latency. Typically, DILI is about 12 weeks, 6 months, majority cases, but autoimmune DILI can present after months, even years of exposure. And there are autoantibodies. Identification is very crucial. There are medical legal cases where patients were treated as autoimmune, turned out they were on minocycline for years. That's never been discontinued. And the patients do respond to steroid therapy. Many times you can continue steroid therapy. Interestingly, autoimmune DILI does not seem to have the same HLA signature as autoimmune hepatitis. More work that needs to be done. But early signal, there doesn't seem to be sharing of genetic risk. There sometimes DILI can present after long latency. We already touched on. Interestingly, DILI with long latency doesn't seem to necessarily have a different phenotype or severity. There are some drugs that can cause chronic liver disease. I've seen patients who are presenting as chronic hepatitis of unclear etiology. It turned out they were just taking diclofenac, which we know can cause chronic hepatitis, and the number of examples like that. Once again, reiterates keeping drugs in mind when you're evaluating any patient with liver disease. An area of interest to me is DILI in patients with underlying liver disease. I got into DILI in sort of late 90s. This was when statins were being used with increasing frequency, and the package insert said statins not be given patients with active liver disease. So we have done many studies in this area. Two things, when you look at this area, there are two aspects that require discussion. One, if a patient with liver disease gets DILI, are they at higher risk for poor outcomes? Generally, yes. And then the second is, are patients at liver disease at risk for DILI? That's controversial. So late High Zimmerman said, there is no evidence that liver disease increases risk for DILI. However, unfortunately, if a patient with chronic liver disease gets DILI, they're not going to do as well. And this is a paper that we published now 5-6 years ago, basically showing what Dr. Hy Zimmerman observed, that if patients with underlying liver disease get DILI, their mortality is about 3 to 4-fold higher compared to patients without known liver disease. There is another paper that's now coming from Spain confirming our observation as well. How about the first question? Do patients with liver disease have a higher risk for DILI? This is a paper, once again, Craig, Lammert, and I published in CGH last year, searching our databases to ask this question: do patients with liver disease or suspected NAFLD have a higher risk for DILI if they receive our top 10 hits? You may remember the top 10 agents that I've shown, top 9 are antimicrobials. So we constructed a study where there was a chronic liver disease cohort with 25,000 people and then 2 control groups. What we have shown, though, is when suspected NAFLD patients receive one of these 10 compounds, their risk for DILI in next 2 to 3 months, I think it was a 12-week follow-up, was 0.8 compared to, this is significantly higher than control groups. Odds ratio is about a 6-fold higher. There is one other paper in the literature suggesting the same thing. This is quite epidemiological signal, but others are trying to test if NAFLD is risk factor for for DILI. But at the moment, it remains controversial. Drug-induced hepatic steatosis, textbooks talk about methotrexate, corticosteroids, but the one that you all should remember is tamoxifen, especially if you use it longer term. Now the recommendations are used up to 10 years for hormone-sensitive breast cancer. There are 2 FOB inhibitors, lamidopide and mipomersen, mechanism-based hepatic steatosis. Interestingly, 2 compounds in phase 3, peglyspro and glucagon receptor antagonists. These are Lilly compounds, already hundreds of millions of dollars were spent, and they both were discontinued because these compounds cause hepatic steatosis. And interestingly, there seems to be a relationship with PNPLA3 GG allele. Just touching on a few other classes of agents that we frequently use: TNF-alpha antagonists, infliximab, etanercept, and edelizumab. These cause DILI, approximately median latency of 13 weeks, positive autoantibodies. They typically have autoimmune type of phenotype, and they respond to steroids. And generally, this is a class effect, but there are reports where clinicians were able to play around with different TNF-alpha antagonists, perhaps a gradual dose titration to restart TNF-alpha antagonists. A big class in the cancer space is TKIs, tyrosine kinase inhibitors. There are more than 50 small molecules that are protein kinase inhibitors, and they all many have liver liability, and in clinical trials, up to 25% have increase in ALT. 2% may have high-grade ALT, meaning 5 times increase in ALT. Post-marketing, you see serious liver injury with jaundice, rare fatalities, typically this hepatocellular pattern. Once again, I think you could re-challenge once the liver injury subsides with a different TKI, but start at a lower dose with a careful monitoring and informed consent. And of course, it is all risk to benefit ratio. Immune checkpoint inhibitors are the big thing. They're, as you know, revolutionized the cancer therapy. Both broad classes, CTLA4 and PD-1, can cause hepatocellular injury. Typically, you don't see autoantibodies. Interestingly, jaundice is rare. And the oncologists are really exceptionally good at identifying and managing them with steroids, rarely mycophenolate and cyclosporin. And the combination seems to be more hepatotoxic than either one of them. If interested, there is an excellent review article published from Mike Charlton's group a few months ago in Hepatology. He's one of his associates. He's the first author on it. Finally, statins and DILI. Dr. Hy Zimmerman said statins bark but don't bite. That turned out to be the case. Bunch of work we have done. Some of the work to show that the statins are safe even in patients with underlying liver disease, even statins. My rule of thumb is do not give statins to patients with decompensated liver disease, i.e. if somebody has jaundice, has had variceal bleeding, because pharmacokinetics change, that's one. Number two, the rule of thumb is if you're giving a statin to somebody with fatty liver, as long as bilirubin is staying normal, i.e. direct bilirubin, I have tolerance up to ALT 200 to 250, and as long as they're not symptomatic. So now statins have revolutionized cardiovascular disease prevention, especially patients with NAFLD have exceptionally high risk for heart disease. Therefore, I strongly encourage using statins. And then, by the way, the package insert no longer recommends liver test monitoring. I personally advise patients when I give statins for muscle aches, myalgias, dark urine, turning yellow, not feeling well. But I've not been routinely testing liver biochemistries after starting those statins. Just draw your attention, which you may already know, liver tox, painstakingly put together by Dr. Jay Hoofnagel, a fantastic resource for looking up DILI bedside. If you have a patient you're wondering, it is really encyclopedic. And now this has been built into PubMed. Now the entries into liver tox actually show up on liver in PubMed as well. This is the search engine I frequently use, and my team uses this quite routinely as well. To summarize, as I said, DILI is a diagnosis of exclusion. One must keep this in mind for all new hepatology referrals. Autoimmune DILI must be kept in mind because it is potentially treatable just by withdrawing the agent. Chronic liver injury may occur. IBD drugs, TKIs, immune checkpoint inhibitors are DILI prone, and they are the sort of the big group now, along with herbal and dietary supplements. My advice is if you are managing patients with cirrhosis, I advise to avoid nitrofurantoin, minocycline, and augmentin. This is not evidence-based, just the fact that they are the common culprits. And you may consider such a recommendation as well. Prompt recognition is critical, and re-challenge is ill-advised except when it is when the risk-benefit favors a re-challenge, such as you're treating a patient with liver disease, cancer. And I want to thank you for your attention, and I'd be happy to answer any questions you may have.
All right, if anyone has any questions, you can maybe unmute your mic and go ahead and ask, or if you would like, you can type it in the chat area and I can read it for Dr. Chalasani.
Thank you for that talk, Dr. Chalasani. Quick question about the question of whether there's individual variation and what we know about the microbiome now. Do we suspect that could contribute to drug difference in metabolism and liver toxicity? Is there any evidence?
There is some experimental evidence. I haven't seen anything human. Some experimental evidence. Roth's group used to study endotoxin, and then I think with diclofenac animal model, I think there is a microbial signature to sensitivity to DILI specific compounds. Hard to test in humans, just as you know, it's such a rare. But that could be a reason why antimicrobials might be a sort of a common culprit.
I have a question about statins.
Sure.
Okay. Can you hear me?
Yeah.
Okay. Now, in cardiology, that's very commonly used drugs. Sometimes we put people on statins and their liver functions deteriorate ALT close to 3. Can cutting down the dose of statins help, or should we just stop them?
No, that's a really good question. Thank you. Thank you for asking. I want to first make one thing clear, though. Just because aminotransferase is increased, that's not liver dysfunction. So I think when you are treating or somebody is giving statins, I'd like the clinicians to pay attention to a couple of things. One is increase in direct bilirubin. If there is an increase in direct bilirubin, that's when you start paying attention. The other one is the height of ALT increased 3 times. I probably with normal bilirubin, that doesn't really bother me. So I would want just a word of caution about using liver dysfunction. The second, though, is if it is, some patients are uncomfortable. I may be comfortable. They say, I don't like it, doc. I don't want my ALT to be 120. Dose reduction is very reasonable because aminotransferase increases with the statins is very dose related. So if somebody is on 80 of a statin, cutting to 40, or even just giving a holiday, starting a lower dose is very reasonable. If you are, of all the statins, pravastatin seems to have a lower aminotransferase noise compared to others. But I mean, you know, when I asked experts who have used lipids extensively, they said they've never really seen a case of jaundice from statins.
Thank you very much.
So Naga, a couple questions. One of the things that we see once in a while, especially from soldiers at Fort Knox, where they do a lot of exercising, pump a lot of iron, they come see us with elevated ALTs, and we think it might be due to some of the supplements they're taking, but instead it turns out to be just the pumping iron. Do you see that at all?
Really, really interesting. I've not seen that. That I think is really worthy of further investigation, because many cases that we enrolled in Delhi have come from Army recruitment sites. For example, Oxy Elite Pro, the outbreak was in the military. And then Herbalife was, and more Garcinia, I think Kratom, but we never really picked this up. And I think we do have a collaboration with DOD. I'm taking notes, I'll follow up on it. Sort of makes sense though, high dose, because it's such a reactive compound. You know, it could at least prime other compounds for hepatotoxicity.
And
sorry, go ahead, Dr. McLean.
You made the point about checkpoint inhibitors, which I think is incredibly important. So about a year ago, I was consulting for a couple of companies where they were reviewing all of their toxicity, and where GI toxicity is managed very easily with steroids. One of the biggest things where we look back to see where people died of liver disease, it was discontinuing steroids too early. So when these people get their liver injury, they need to be kept on steroids for an inordinately long period of time. And I think that's something that people in the community don't do. I don't know whether you've had that experience too.
That's interesting observation, Craig. In a paper that we published with MD Anderson, Miller is the first author on it. We reported 100 cases over 5 years of really well-defined DILI from immune checkpoint inhibitors. A couple observations. One, jaundice was very rare. Interesting. That may just be the oncologist and MD Anderson right off the bat. The other thing was the mortality was from interruption to their immune checkpoint inhibitors.
Right.
We just didn't see that. So you're absolutely right. I think keeping them on steroids, restarting immune checkpoint inhibitors, and figuring out a way to manage the cancer is the right way. I think in the end, this is probably going to end up being sort of a nuisance rather than cause of death, I'm thinking hepatotoxicity from immune checkpoint inhibitors.
Jason, did you have a question?
Yes, so we have a question, and one of the questions from the chat area is, what's the steroid regimen you would use for autoimmune DILI?
Really good question. So it depends on the severity. So I would treat like any other autoimmune hepatitis. For example, somebody comes with jaundice, higher dose and longer taper, as opposed to somebody just as aminotransfer is increased, I would probably just try to use 20 milligrams of prednisone or more recently budesonide. And I think you see this with nitrofurantoin, where some, if you identify drug-induced, actually you can take some liberties by stopping the drug and see what happens if they're not profoundly jaundiced. If somebody's bilirubin is 2, INR is normal, I may just stop nitrofurantoin and see if they rapidly respond without necessarily subjecting them to steroids. It is really the liver dysfunction that sort of drives what kind of a regimen I would use.
All right, that was the only question from the chat. So if anyone else has anything.
Dr. Chalasani, can you hear me?
Yes.
Yeah. Hey, what would you, can you clarify what you consider as the upper limit of normal for ALT, since you use that as a lot in your evaluation?
Wow, you touched on a very, very, very controversial point. We don't quite know what is the upper limit of normal. Generally, though, 31 for men and 19 for women is what we do in our studies. For clinical practice, I would probably use 40 to 45 as sort of your general rule of thumb. Because if you use 31, and there is just so much background fatty liver, 30 to 40%, so you're going to get into a lot of noise there. So 40, 45 is sort of general rule of thumb for clinical practice.
Great, thank you.
Do you agree, Craig?
Absolutely. So we want to thank Dr. Chalasani for a fantastic grand rounds with a lot of great clinical pearls. And for our outside speakers, we always get them a special present. So you're not only going to get a check, but you're going to get a bat. So Jason, show him his bat there.
Yeah, Dr. Chalasani, This is what you're gonna get a Louisville Slugger bat that's inscribed Naga Chalasani, MD, the 2020 Redinger Lecture, University of Louisville, December 3rd, 2020. That's what
What a
it
privilege.
looks like.
Thank you, Craig. Thank you, Jason, for your help. I really appreciate the opportunity. Thank you so much.
problem.
So,
Thank you.
absolutely great grand rounds. Thank you very much. And we look forward to getting you here in Louisville once COVID's over with.
Thank you, Craig. My privilege.
Thanks again.
And thank you, everybody. We really appreciate Dr. Chalasani joining us. And Dr. McLean, thank you for the assist as always. And this was wonderful. And we will be back next week, and our speaker will be nephrology based, or invited by nephrology by Dr. Breyer. It's Agne Painter from Rush University, and that will be on December 10th, next Thursday. We will have one more before the holiday break on the 17th, and that will be Dr. Umair Gauhar from our pulmonology division. So that's it.
Great job, guys.